our topic is abdominal pain and how to safely discharge. Okay, it's a very important topic because we will encounter a lot of patient dengan dia punya main symptoms is abdominal pain. So I will start with the case scenario. Okay. Sorry. Okay, just imagine yourself in a very busy ED. Okay, I'm talking about COVID ED. Right? There's a 75-year-old gentleman with underlying DM, hypertension, presented with right flank pain radiating to suprapubic region and with associated symptoms of dysuria and also urinary frequency. Okay, so kita pun assess patient. Dia cakap pain score about 6 to 10, 6/10. Pain described as colicky in nature, otherwise no relieving or aggravating factor. Upon further history, patient has no fever, no vomiting, no loose stool. He claimed the bowel movement is normal and also there is no hematuria. Okay, so kita assess patient and then kita ask the staff to check vital sign, right? So patient vital sign dia BP a bit high, hypertensive 170/90, tapi kita macam okay lah 75 years old, right? Pulse rate 110, tachycardic, SpO2 under room air 100%, and then patient is afebrile. Okay, so kita pun fikir lagi. Okay, so I proceed dengan examination lah. Right, while houseman tengah ambil darah ke apa kan. So you examine patient. Tengok patient alert, conscious, not jaundice. Tengok not septic looking. Right, CRT pun less than 2 seconds, good pulse volume. And then kita proceed dengan auscultation. Tengok respiratory, equal breath sound. CBS dua regional movement. And then okay lah, patient came with abdominal pain. So kita most important kita check the abdomen. So abdomen, we examine, saw, palpate, no guarding, not distended, no organomegaly, renal punch negative, bowel sound present, macam okay, nothing much, right? Cranial orifice intact. Okay, last kita pun okay lah, buat PR lah last kan. PR, colorectal, no mass, no melena, no prostatomegaly. So from here we are still like apa patient ni lah, semua macam negatif je, apart from the mild tenderness. So okay, kita minta staff tolong buat ECG, houseman punya blood. ECG tengok sinus rhythm, blood investigation all within normal range. Right. So we are more baffled lah. Okay, kita pun proceed with bedside ultrasound. What bedside ultrasound? No free fluid, liver normal echogenicity. Tengok gallbladder no sludge, tak ada stone, kidney all normal, abdominal aorta documented as 1.7 cm. And then we ambil urine FEME, ada erythrocyte 1+, ada parameters are normal, EST pun normal. So at this moment, I think most of us will still like, what is happening to this patient, right? Okay, last pun kita pun tak tahu sangat. Okay, patient in pain 6/10. Okay, bagi trauma lah, semua tolong endorse trauma. Okay, and then patient after that claim still having abdominal pain but slightly tolerable. Kan? Okay, tengah busy ED, suddenly your senior MO datang, bro, ada OSCC case lah, tolong attend tak boleh. And then you pun, okay lah, bos senior MO suruh kan, Buloh. And then you tak sempat nak fikir apa semua, and then you just like, okay, give patient reassurance, okay, nothing much going on to you apa semua, and then we discharge. We put uncomplicated UTI. Patient was discharged with analgesics and antibiotics. Okay, so now I nak make a poll. What do you think? should this patient be discharged? Siapa yang setuju, angkat tangan. Siapa setuju patient should be discharged, boleh angkat tangan. Dekat rumah pun boleh reply kat chat lah. Ini tu engage yang dalam kat rumah. Okay, berapa orang yang ada tak orang yang agree untuk discharge patient at this stage? Discharge lah. Sebab ramai kan busy yang ini. So discharge. Okay. Berapa ramai yang agree untuk need further workup? Angkat tangan. Patient perlu need further workup. Ready? Kita discharge patient dengan kita bagi tramal je, and then tiba-tiba kita kena attend patient lain, so we discharge and that's it. Bagi analgesia dengan antibiotik. Sorry? Sebab patient tu ada dia ada right flank pain, lepas tu ada erythrocytes. Sorry? Okay. 75 years old lah. Okay. So, okay, we proceed lah. So I think most of us agree untuk more further workup for this patient, right? Okay, so actually abdominal pain comprises of 5 to 10% of all our cases in emergency department. Okay, despite sophisticated diagnostic modalities, undifferentiated abdominal pain for the diagnosis. So, of all, 25% discharge, and then between 35 to 41% those admitted lah. Okay, tapi approximately about 80% of patients yang discharged with undifferentiated abdominal pain improve or become pain-free within 2 weeks of presentation. Some studies suggest that mortality rates among older adults with abdominal pain is not determined, right? So next we'll talk about high-risk patient. When patient came with abdominal pain, these are the. I took my touch you. It's on the slide already. Yeah. Video panel lah. Tapi yang bawah tak video. Oh, all right. Okay. So, patient extremes of age, female in reproductive age group, immunocompromised patients, patient with significant comorbidities such as liver cirrhosis. So, this patient where we have to be more diligent in assessing this patient. Okay. So we'll go to a bit in summary of pathophysiology of pain. So in general, we have 3 kinds of pain: visceral pain, parietal pain, and also referred pain. Okay, which also actually make us confused from as to where the origin of your pain. Okay, for visceral pain, it's from unmyelinated fibers innervated the capsule or the wall of an organ, which is less sensitive. Usually the character of the pain is crampy and dull, and then the pain is localized midline despite coming from right or left because of the embryonic origin. Parietal pain is a myelinated fibers, more specific, innervated the parietal peritoneum, and also referred pain also has something to do with embryological development, usually on the same side, only felt in midline if the pathology is midline. So because of the embryological origin, the pain usually makes us confused from where does it come from. Okay. Thus, we have an approach to abdominal pain in patient. So when patient came with abdominal pain associated dengan peritoneal signs, shock or toxic appearing, okay, patient ada rigidity, pain out of proportion upon palpation. So and then ada shock. So for this patient, we straight go to initiate resuscitation, and then kita consult surgical and do the needful imaging studies. Right? Otherwise, patient datang abdominal pain tapi not in shock, not toxic, peritoneal signs negative. So this one is on the right hand side too, is our differential diagnosis that we have to rule out lah, step by step. So patient if ada the symptoms suggestive of SES, okay, typical chest pain apa semua, so we will go to the appropriate management for SES. Tapi kalau tak ada, then kita cari pula ada differential diagnosis. So we go to abdominal aorta aneurysm. Okay, ada symptoms or signs or risk factor. Okay, anyone can tell me the signs of abdominal aorta aneurysm? Signs and symptoms ataupun anything, any information that suggestive of AAA that makes us think that okay, maybe AAA kita tak rule out. Anyone at home also can reply on the chat. Semua tak ada.
Maksudnya tak ada kat front. Maksudnya pajak datang saya ambil.
Okay, can anybody tell? Consenting mass, okay. Lagi? AAA. I mean like any information yang you makes you think that okay, maybe it's a AAA. Okay. BP high, radiofemoral delay. Usually the pain is
new onset and then quickly we get to the back.
Right. Okay.
And then this type of AAA basically if fractured, if hemodynamically is unstable, you might worry a bit because maybe possible of fracture AAA lah. And then if there's risk of AAA, those risks macam fracture AAA tu usually old age risk of fracture.
Okay.
And then smoke, you smoke, you have hypertension, and also female is higher chance to have AAA dalam few studies lah.
Okay, thank you. So risk factors dia, patient ada old age, more than 65 years old, ada history of tobacco smoking, ada family history positive, and also ada atherosclerosis ke. Right, so this one ada risk factors for AAA. So if yes, then we will consult surgical, and also the best diagnosis is through CT lah. Right. Otherwise, okay, if we don't think it's AAA, so we go our next differential diagnosis is mesenteric ischemia. Okay, again, mesenteric ischemia. Can anybody tell me what are the signs or symptoms of mesenteric ischemia? I mean, again, any data or information that makes you think it's mesenteric ischemia. Severe abdominal pain. Lagi?
Ischemia, if you pain control is proportionate lah. If you pain control, so they will feel the pain lah. Memang susah to control the pain for ischemia.
I add if it like in history, patient sometimes can dia punya onset of pain is very acute. Patient ada history of postprandial pain that makes them ada food fear, like they takut nak makan because every time they eat, diorang sakit. So tapi jangan tirulah, nak diet ke apa, do it properly. Okay, so and then if yes, then again we go to surgical consultation and also abdominal CT. If not, our next differential diagnosis is to rule out bowel obstruction. So basically, for me, I will think of cardinal signs. The 4 cardinal signs: patient ada abdominal pain, abdominal distension, vomiting, and also constipation. Right? So kalau yes, again the same. If no, then we go to bowel obstruction. Okay. If bowel obstruction, yes, we will obtain abdominal radiograph series. So we'll see if we can find some free air, ada obstruction on the abdominal CT, ataupun basically free air and also obstruction. If all is negative, then we kena localize lah. We try to localize where is the pain. For epigastric, kita kat sini we divide into epigastric, right upper quadrant, left right lower quadrant, left lower quadrant, and left upper quadrant. So for epigastric and right upper quadrant, okay, so patient ada pain localized dekat situ. So kita boleh buat, what you can do ultrasound, bedside ultrasound, can obtain blood sound like paste, amylase, to rule out kalau ada pancreatitis ke. And if no, then we go to right lower quadrant tenderness. Okay, right lower quadrant tenderness, we have female and also male lah, different sikit. So for female, we can perform pelvic examination by manual digital examination that can give us some ideas about the pathology. And also for male, don't miss the tender testicle or tender scrotal mass for torsion, testicle torsion ke. Okay. If yes, then we go to urology consultation. If no, since it's right lower quadrant, so we're thinking of appendicitis. So appendicitis, we refer to surgical also. Over the left lower quadrant, okay, basically initial evaluation kita sama dengan right lower quadrant, and also we can add CT to diagnose diverticulitis. Okay, and then left upper quadrant ni for signs and symptoms of infectious mononecrosis. Infectious mononecrosis patient also boleh can come with tender left upper quadrant from the spleen tender spleen. Okay, approach to abdominal pain in female of childbearing age. Okay, again we start at the top. Kalau patient datang with peritoneal sign and shock, straight we will resuscitate patient, obtain surgical consultation, and also do bedside ultrasound. Okay, if patient is tak ada peritoneal signs, so we are thinking of patient is she pregnant or not. Okay, that's very important. If patient is pregnant, then we have to obtain ONG punya consultation lah, right? And also what additional thing we can do, we can take beta HCG and other indicated laboratory tests. If patient is not pregnant, then kita check if patient ada unilateral adnexal mass. So this one to rule out is either patient ada ovarian torsion or clinical PID. Okay. I think I go to the next slide. So these are the 9 quadrants of your abdomen. Okay, if you can, as you can see, there are many overlapping pain between quadrants. Okay, that's why sometimes it's very hard for you to diagnose according to the organ. Right? And here I want to emphasize the dangerous mimics of abdominal pain. Okay, so you can see initial misdiagnosis and also true diagnosis. Sometimes we are thinking of gastroenteritis. But then patient actually the true diagnosis is appendicitis, right? Patient ada constipation, ada pyelonephritis, that's our initial thought. But then patient actually true diagnosis is diverticulitis. So these are the dangerous mimics lah. I think this is very often happen. Our initial diagnosis is different from the true diagnosis. Okay, next we'll go to the red flag symptoms of abdominal pain. So if patient came with sudden onset of abdominal pain, okay, ada associated hematemesis, unexplained weight loss, change in bowel habit for more than 3 weeks, unexplained PV bleeding, postpartum bleeding, associated dengan SOB, dysphagia, increased vaginal discharge, okay, ada persistent unexplained vomiting, testicular pain, and also elderly. So these are the red flag symptoms that we tak boleh miss lah. Okay. So dalam red flags pula, we can divide it into medical red flags and also surgical red flags. So this one can give us an idea which pathway kita nak pergi lah. So if patient came with septic experience, respiratory symptoms, significant dehydration, ada petechial rash, patient jaundice, so this one medical. Okay, kita ada medical ni thought satu. But then patient kalau ada peritonitis, ada history of recent abdominal trauma, recent abdominal surgery, and kita takut ada dehiscence of scar. So this one we're thinking of surgical. But then both can be combined if patient ada severe increasing abdominal pain, blood in stool, abdominal distension, and then ada palpable abdominal mass. For child, the kids is unresponsive or excessively drowsy. So basically for the medical and surgical ni is more direct lah kalau macam patient ada peritonitis ke apa. But then if it's very vague apa, so it can be either medical or surgical. So next, we will see the clinical pathway of imaging. So basically, we will this one is for imaging. For patient with clinical suspicion of bowel obstruction, ada foreign body viscous perforation. If yes, then we will go for first kita akan buat radiograph. Kita nampak kat atas radiograph lah. Right, X-ray. If no, then macam kita pergi tadi kan, the algorithm. So kita nak decide is either X-ray, ultrasound or CT. Okay. And then if tak ada, we are not thinking of bowel obstruction, foreign body, viscous perforation, but we are suspicious of pancreatic disease, the AAA, appendicitis in pregnancy. Then our best next modalities is ultrasound. If no, we are thinking of diverticular disease, intra-abdominal abscess or bowel obstruction. The one is kita akan proceed with CT. Okay, these are the common diagnosis lah for acute abdominal pain in adults. Okay, it's very wordy, tapi I will just highlight a bit on the important part lah. Okay, for appendicitis, actually CT is preferred in adults and also non-pregnant women. Okay, in cholecystitis, ultrasound modalities is about 81% sensitive. Okay, and if patient dengan mesenteric arterial occlusion, so that one kita usually the lactate will be high lah. Okay, lactate will be high, so that can give us an idea about it. Pancreatitis, contrasted CT is the golden standard, and also ultrasound may show you edema. Okay, here rupture ectopic, transvaginal ultrasound can give you a picture of it. This one can go through nanti from the slides kita bagi. Okay, so you guys remember the case from the case scenario? Okay. Okay, patient 75 years old tu datang dengan right flank pain, ada dysuria, dysuria and also urinary frequency. So actually, this is a story adapted from Abang Randy punya experience. So the progress of the case, patient subsequently returned back with worsening abdominal pain on the next morning. And then we do further investigation. We take what contrast enhanced CT. Noted patient there's right common iliac artery dissection. However, there's no evidence of fracture. So patient are referred to surgical team. Okay, so patient datang balik. Basically, patient datang balik with the persistent pain. Okay, so take home lesson from this case. Patient presented with persistent abdominal pain despite adequate analgesia should be subjected to frequent reassessment and further investigation. Okay, and high index of suspicion if the patient is from high risk group. So patient basically are 75 years old, extreme of age. So kita kena lagi diligent lah. Okay. So next, these are some discharge pearls for every differential diagnosis kita lah for patient. Okay, so basically patient yang abdominal pain with unknown etiology, okay, kita advise patient if the pain does not resolve within 24 hours, please datang balik. Discharge pearls ni kita punya advice to patient. Scoring system and criteria ni are the necessary to safely discharge patient. Okay, so if patient persistent pain, they develop fever, develop weakness, nausea, vomiting, and then ada blood in stool, then this one patient can check up. Okay, if you develop all this, please come back to us. Okay. Untuk discharge pula, patient make sure patient have no sign of symptom or with sepsis or shock, can tolerate oral intake, and also have negative diagnostic workup, including imaging of auscultation lah. If patient signs and symptoms were subjective or surgical disease. For cholelithiasis, if our diagnosis is cholelithiasis, we can consider discharge patient if there's no signs of acute cholecystitis, vital sign normal, okay, normal lab including lipase. When kita scan ke apa, common bile duct that is not dilated, and patient can also tolerate oral intake well. Okay. So bila discharge, what we advise to patient, eat low fat diet, okay, return back to us if they develop pain in right upper quadrant lasting more than 2 hours, okay, patient tak ada jaundice, make sure kalau ada jaundice ke dark urine or light colored stool, please come back to us lah, okay, and also make sure patient kalau is cholelithiasis ada follow up with surgery for elective cholecystectomy. For PUD, make sure bila discharge patient tak ada bleeding, there's no more bleeding, there's no bleeding, no perforation or no obstruction. Okay, and then advise patient untuk avoid any non-steroidal anti-inflammatory use. Okay, and also can consider for patient to treat for Helicobacter pylori lah. Okay. For uncomplicated diverticulitis, make sure kita when we want to discharge patient, there is no associated abdominal distension, no vomiting, able to tolerate fluid and take medication. Pain is controlled with analgesia, and also can follow up with physician in 2 to 3 days, able to take care at home lah, for self at home. And advise patient to return if the abdominal pain does not resolve or no fever. Kalau ada fever datang balik. If there blood in stool, vomiting or signs of obstruction. Okay, for GI bleeding, I think everyone ada phone with you. Okay, we can check the apps MD card. Boleh buka. There's a score. The Glasgow Blatchford bleeding score. Yang kat rumah pun boleh tengok ada apps on MD calculator. So basically this is a score to to identify patient who are likely needing a transfusion ataupun intervention lah. Okay, so kita boleh just check dekat situ. Patient, kalau patient with score less than 1, then we are quite confident to safely discharge them. Okay, and then kita ada satu lagi scoring untuk GI bleeding, AIMS 65 score. Yang tu pun ada dalam MD calculator. Okay, so basically this one is the rate for mortality rate in hospital lah, in inpatient. Okay, so this one I will advise the patient to discontinue any non-steroidal anti-inflammatories, to return back if patient develop SOP, dizziness, general weakness, chest pain, and then persistent bleeding ataupun vomiting blood. Okay. For pancreatitis, if our diagnosis is pancreatitis, we also have a score. I think this one pun ada dalam MD count. It's called harmless acute pancreatitis score. Okay, so this one to identify low risk patient who are unlikely to have a severe clinical score lah. So this one dia ada check creatinine level and also hematocrit level. Itu boleh tengok dalam ni. And also to discharge this patient, we advise patient should improve their abdominal pain within the next 72 hours. Okay, they need to maintain well hydrated, and they should return if they develop worsening symptoms, if they have persistent pain, weakness, nausea, vomiting, sama. And also kalau ada fever, high grade fever. For pediatric gastroenteritis, okay, to consider discharging patient should be not to be severely dehydrated, bukan neonate, and also can tolerate oral intake. So advise the parents to return with the child if develop fever, abdominal pain, and or bilious vomiting. So this one is the template. I think before this dekat green ada to discharge patient, we give advice macam ni lah. Okay. So I think that's all for me. These are my reference. Thank you.
Soalan?
Any?
Presenter semangat nak jawab.
The introduction tak ada dalam macam OCC semua, but then the first presentation we discharge, first meeting is PI, and then the second visit when we the problem is this is our mistake lah sometimes, because we only scan the abdominal aorta, just one part je, kita tak extend sampai coronary artery. So basically kalau kita nak buat focus tu for abdominal aorta, you have to detect from the determine from the level, because sometimes you can miss the small, very small abdominal dissecting aneurysm, because sometimes dissecting aneurysm dia takkan besar, takkan increase more than 3 cm size. Because that's something. Actually ada 2 cases kot. Yang first cases tu sister in Selangor went for 3 hospital visit. Similar presentation is more like UTI symptom. So came to USM, came in with complaint of AUR. So my colleague is a CPD and then put in green zone tapi tak ada urine keluar. So when my shift night time datang, patient is still there in pain. I took the ultrasound, nampak around 7 cm triple A lah. So actually for triple A is the most common, I think 90% mortality and easily miss kalau kita tak access properly lah. Somehow baseline investigation, contoh macam other diagnosis like acute abdomen, contoh pancreatitis, kita ada amylase, And then macam kalau triple A ni, the only bedside diagnostic that we can do is apart from physical examination is ultrasound. So basically we need to extend our scan to from up down to verification of pulmonary artery and then also electron.
I totally agree with you that especially in a busy hospital, we tend to like just give very basic first line treatment and that's it. Like, you know, he said his colleague just inserted a CBD, sent to green zone. It's very common among big hospitals, especially kalau my previous experience in HKL. We love to give cocktail for abdominal pain in green zone. Trauma, Maxilon, ranitidine, syrup MMT, discharge. The next minute brought in dead. Very common. If we don't do it, the MAs in the triage also will do it. Sebab waiting time very long. Green zone dekat HKL jauh. So diorang akan bagi dulu semua step medication dalam satu syringe. Z. Send to green zone. By the time the doctor see dah rigor mortis kat luar. It always happen. We want fast treatment, we put all in a syringe, give one shot. Very common lah, trauma, maxilla, ranitidine, syrup MMT, that's it. And elderly abdominal pain is something which I hate to see in green zone. I really hate it because they come in say, oh, sakit lah, ancak angin lah. What the hell is that? Angin? Benda angin. So very, very complicated. I really hate to see abdominal pain in elderly. Very easily missed. Huh? Okay.
Assalamualaikum, everyone. I think most of us have forgotten the channel of managing managing an abdominal pain. So most of us has forgotten the use of our hands. Right? Because in the slide, I don't see anything about physical examination, abdominal examination. I think the only problem with us right now is we rely solely on our bedside ultrasound, our adjunctive investigations, but we forgot how to use our hands. And so how does triple A give us a clue based on physical examination? We palpate, kita palpate, kita rasa if there's any pulsatile mass, whether the mass is huge or not, kita try to identify, try to demarcate the size, try to demarcate the edges, and then we determine the size. And what happens after that? Kita akan tengok sama ada radio femoral theory atau tidak. Kan? Lepas kita akan letak stethoscope di situ sebab kenapa? Because we want to listen to bowel sound. Kan? Nak tengok bunyi apa, bau bunyi ke, kan ada ke, tak ada ke bau sound. Jangan pergi ke sana nak dengar bunyi atau tidak. Lepas nak pergi ke sana, ni atas sikit, nak dengar dekat adrenal artery dia, ada bunyi atau tidak. Nak indicate dia ada adrenal artery stenosis atau tidak. So, physical examination is actually, it's very important because that will give us a clue what's actually going on with the patient. Yeah. So with that, that will lead us to deciding what other adjunctive examination that we want to perform and what management that we want to advocate for the patient. Right? So untuk presentation yang selepas ni, try to include more of physical examination, right? Supaya kita recall balik. Sebab kita dah lupa kan. COVID kan saya pakai ultrasound, lupa pakai stethoscope nak dengar ke jantung, lupa nak pakai stethoscope nak dengar paru-paru, kan? Abdomen lagi lah, kan? Apa yang dicakap tadi pasal ultrasound di abdominal aorta, yes, because most of us we try to make it quick. By placing the probe at a single area, size dia macam ni. So Dengan itu dia akan memberi kita idea yang okay, in Thailand we have the same diameter. But know that it doesn't apply that way. You have to inspect the entire length of the abdominal from top to bottom all the way down to the bifurcation somewhere at T10 level, and then you extend all the way down until the common iliacs. And then you will able to, then only you can comment. That is a normal abdominal aorta. So daripada atas, from your celiac trunk to your SMA, SMA, superior mesenteric artery, inferior mesenteric artery, kita nampak sangat. And all the way down to your bifurcation, your T10, and extend down to your common iliacs. Then only you can comment. Okay, ni size ni dekat mana, SMA macam mana, celiac trunk macam mana, bifurcation macam mana, berapa diameter dia, kan? And then common iliac berapa, then you can see normal abdominal aorta. If you don't examine the entire length, you cannot comment. Yeah? Like what I said just now, dissection doesn't mean that the vessel is huge. It can be normal in size. And the only problem is it's dissected. Even in this case, I'm sure if you perform, if you try to determine whether there's radiofemoral delay, there must be delay. There must be delay. Sebab kenapa it's dissected? Kan? Mendalam tak cukup sebab dia masuk dalam false lumen. Kan? So I'm sure there must be some form of radiofemoral delay. So remember, physical examination is the paramount. And then only you will decide what you want to do after that. Okay, thank you.
Good morning, everyone. So first of all, good presentation. Thank you, PDA. So very informative, and as we know, abdominal pain covers all genre of our people category, like from pediatrics all the way to elderly. So it's a lot of information to digest. So the other thing that I want to highlight on is pregnant and childbearing age women. So don't forget that abdominal pain in them is also high risk. It's also you have to look very, very deep into. So if let's say they are childbearing age, a negative UPT does not totally rule out your ectopic. You can still have ectopic despite negative UPT. So if you suspect, go ahead and further order tests or get gynae to involve as well. Because like what Iman mentioned earlier, transvaginal scan is actually the gold standard. So your transabdominal scan might not be able to catch all this. That having said that, don't forget other things such as all your endometriomas, your ovarian cysts, all your hemorrhagic cysts, molar pregnancies, and then even if patient is on fertility treatment nowadays is very common. So don't forget your OHSS, ovarian hyperstimulation syndrome. Okay, those patients can come in with category 4 with ascites, severe abdominal pain, and all. So you have to look into those also to make sure that part of the history is also gathered very well. Yeah. And then make sure if you have a female patient with abdominal pain, try to gather a lot of the menstrual history. That can give a lot of clue, because it could be something recurrent, something very acute. Ask about infertility, yeah, see if she's under any follow-up or not. Don't forget that. Yeah, LFP, make sure documented. Okay. Then if let's say the patient is pregnant, having abdominal pain, that's even more high risk. You can be dealing with the surgical, non-surgical cause. You can be dealing with the pregnancy, non-pregnancy cause as well. So please make sure, first of all, I emphasize again what Mar said, examine the abdomen. Make sure there's any peritonism sign. If it's hard, tender, like wood-like rigidity, you're worried of a concealed rupture or a revealed rupture. So of course get gynae involved as soon as possible. Yeah. And then if the patient is in shock, resuscitate them accordingly. If let's say it's a surgical issue like cholecystitis or appendicitis in pregnancy, you get surgical involvement. Okay, but again, resuscitate accordingly, and also as soon as possible involve all the other things to also accommodate and help you to further intervene. Okay, any other questions?
Assalamualaikum, good morning. Sorry, just not clarifikan with bosses, and especially regarding this case, was it fair to discharge the patient in the first place? Because from the explanation given, the pain was resolved after pain medication was given. All the initial investigations were normal. There was no pain flex signs except for the age. I believe that the patient could be discharged, but if during the second presentation, yes, it is where it does warrant for more investigation, because from the presentation given, ultrasounds, everything was already done and it was all the normal. So I want to know what's his opinion regarding this. Thanks.
Reflex is tolerable. Ada reflex tapi tolerable. Okay. So this patient was not supposed to be discharged in the first place because pain was still there. Okay. Well, I think during the first encounter too, I'm not sure how the physical examination was done. Remember all the population with multiple comorbids coming in with abdominal pain. You think that it's like a pyelonephritis or renal colic? Always think of abdominal aortic aneurysm. Always think of that. Yeah. If it's on the right side flank, there could be cholelithiasis or double choledocholithiasis. Could be that. Yeah. So, but your main priority in order for you to safely discharge a patient is to rule out abdominal aortic aneurysm untuk orang dulu. Lepas tu, if the pain is from there and it releases all the way down to the groin, and have a look at the testis, and could be torsion for because kebanyakan torsion akan affect a younger generation, adolescent dengan teenagers kan. Tapi there are certain cases, there have been certain cases where older generations develop torsion. Ada juga. Tak semestinya torsion kalau ada mass kat situ ke, funky mass ke. So always try to selak semua dia, tengok what's going on down there. Physical examination, and then apa lagi? Ultrasound. Okay, despite the fact that ultrasound has been done, but it was an incomplete study. Right? It should have been done properly, right? Dari atas sampai bawah. Frankly speaking, I myself, I would have missed this case. Right? I would have missed this case. Sebab saya akan dari atas sampai bawah, sampai bifurcation, and then saya akan tilt ke bawah sikit untuk tengok dia punya common leg sikit saja. I would have missed that. Sebab saya tak extend all the way down. Sebab sebenarnya susah juga nak cari sebenarnya kalau nak cari sebenarnya kan. But if you can find, good. If you cannot, yeah. But we don't really advocate going all the way down sampai ke common leg, nak pergi sampai bifurcation internal dan external, lepas tu nak pergi bawah. Memang it's impossible sebab you won't be able to see. Kan? Sebenarnya sampai dekat titan, and then you tilt ke bawah to see the extension of the bifurcation. That's all, and you don't extend all the way down sampai bawah tu, because it's impossible to see. And I would have missed that. But remember, kalau umur 75, umur 65 ke atas, a lot of comorbids can still not resolve. Always have the surgical team to always consult your surgical team to have a look. It's not wrong. You're kata, kenapa ni patient terlalu pun, but it's your case. And we are calling you because we want to get your expert opinion. Itu je. Bagi dia orang sedap. Oh, lama dia orang minta kita orang punya expert opinion. Okay. Bagi dia orang rasa megah sikit. Kalau tak boleh juga, panggil kita orang, we will call the surgeon and we will do the same. We need your expert opinion. Bagi dia rasa megah sikit, okay je, terbawalah.
So back to your dilemma. So I understand the dilemma. Of course, you won't want to take every abdominal patient and then admit and do invasive treatment. I understand the dilemma. Okay? it's a very common thing in every ED. Okay. About 40 to 50% of patients that present with abdominal pain in the US actually get discharged with diagnosis of unspecific, undiagnosed abdominal pain. That's common, but there's a catch there. For that patients, they always come back within 24 hours to 48 hours. They will come back to be reviewed by the emergency department or by their primary care physician. So they have this walk-in clinic and their review back TCA clinic, which we don't cater because our KK cannot handle, our ED also cannot cope. So in that sense, it falls on us to make sure when we discharge, they're not going to come back dead or worse than they were in the first place, right? So what we can do is, if patients is in high risk category, patients who have comorbids or extreme ages, then it is not wrong for you to actually utilize your observation ward. That's what we have it for. So actually you can admit them for a prolonged observation instead of putting them in just yellow zone, giving them a medication. Once the bed is full, oh, he looks fine, discharge. You can admit them to observation, prolonged observe. So if the pain is still persistent, or if you see the hemodynamics start to deteriorate, and you can re-examine this patient. So this will actually help you to catch all these flags that you might have missed in the beginning because you're too busy or anything. But as the patient stays longer, all his other red flags might tend to appear, right? Then you can also repeat serial bloods or serial lactates. Those kind of things can be done for you to actually monitor the patient more frequently, rather than you completely discharge and it's not in anybody's follow-up. That could be a choice. In case you're really dilemma and you think the patient is like this, no harm. Keep for a prolonged observation. So in that sense, anytime you deteriorate or you feel it's worse, you can always get the primary team to have a look and also ask for further imaging. Any more questions? Please. Okay. Okay. President.
For this session, we'll be doing things a little differently. So instead of the typical Google Classroom quiz, we'll be running the quiz through a new website called Socrative. So it's very easy made to download. Shazmi will share it in the MO group. EP group network. MO group. So you guys can just answer. We have a total of 11 questions. So we can just answer it right now in real time. Maybe about 10 to 15 minutes to answer. 2 minutes. Okay, 2 minutes.
26. You just wait at your own pace, wait at your own time, but yeah, wait for me. Wait to see the topic. What's last one? But yours better than yours. Okay, what was it?
To those at home, please put in your real name. I see a lot of unknowns in the portal, so we won't know exactly who you are. Siapa Bella Chow? What?
Oh. Yeah.
Siapa yang dah habis quiz nanti boleh pergi pantry lah untuk breakfast.
So nanti soalan ni akan repeat back. Tapi you ada bukan terus kan?
Tapi mata saya salah. Last time we use it Google Classroom.
You just want to try it.
This one I like to collect. Your opinion. Also your opinion. Well, I like the one that collecting the marks.
But in terms of user friendliness,
Both the same, because because Google Classroom also will want to answer the explanation. Every week sepatutnya ada lah, because we all will be like session dan lepas kita akan
user friendly tak ada website.
Saya rasa semua orang patutnya dah siap jawab by now. I just nak invite you all lah. Dia ada certain tajuk sebenarnya dalam CME jabatan that is a must have every year. So how to safely discharge abdominal pain is one of the topic because banyak mortality sebenarnya comes from green zone, datang abdominal pain very very specific that we tend to discharge because ED is busy. Okay, ED is busy. Kita pun tak nak you all utilize observation ward for semua orang kat yang datang green zone kan. Okay, you have to choose wisely macam Masya ni pernah cakap. So elderly make full use of the observation ward, and nanti pun I rasa I akan present balik pasal AM watch. I think some of you know about the AM watch, so we can make full use of that juga untuk early follow up. But in mana presenter kita? Presenter kita siapa tahu presenter sorry Iman. Okay. But itulah. So this topic is very important sebab biasanya it is from green zone and usually green zone banyak junior MO kan, housewife. Okay, so kalau diorang tend to discuss dengan all the seniors pun sepatutnya kena alarm sikit lah case macam ni, especially yang ada red flags tadi. Presentation ni menjawab tak soalan how to safely discharge, which related to Rahana punya soalan tadi. Setuju tak kita discharge session tadi? Kalau tak setuju sebab dah tahu kes kan in the end. I will agree with Umar, I will probably discharge the patient. But the most important part is how to safely discharge is first is your documentation. Okay, so make sure your documentation you have ruled out all the life-threatening. Yes, it's emergency rules kan. So you tengok apa-apa chest pain, you have to rule out semua life-threatening dulu baru you go for the non-life-threatening kan. Kalau abdominal pain pun sama. So life-threatening dah ada dah. Okay, kalau USF macam ini dengan Randy kalau Prof Kamara dia akan suka tanya what is the definition of diagnosis abdominal pain elderly yang you have to rule out before you discharge. Tak apa mnemonic dia. This is his favorite question, might come out in your exam lah. Okay, dapur carilah DAPOF. Okay, so DKA lagi satu tak mention so DKA can present with abdominal pain okay, tiba-tiba tak ingat apa dia SP ke, tak perasan vomiting sikit-sikit je is DKA symptom. Okay, and then documentation, and then kita ada guideline juga tu, make sure you document juga when the patient should come balik bila kita dah document. Okay, so bukannya discharge as simple as that lah. And then choose wisely patient yang macam mana yang kita kena refer as outpatient. So for example ada je yang red flag tadi, contohnya apa tadi bowel habit, change in bowel habit. Sometimes not necessarily you have to admit, but they need further workup because it's probably SEA kan. Okay, so that one you need to give follow up berapa boleh discharge, very big abdominal pain, ada change in bowel habit, especially dah setahun kan. Okay, documentation and then reassessment lah, documentation of your reassessment, bukannya discharge. Okay, kita assess, okay lah, nampak okay, patient pun kata dah okay, kita pun discharge, betul kita assess, by the way document the reassessment, so kita kena show that yang memang ada improvement of the pain, and then that the pain is still diagnosed as non-specific, it's not a diagnosis lah, but there is no specific diagnosis for the abdominal pain. And then kita dah alarm dia on when to come back. Okay, so that is how you safely discharge patients. So kita akan implement the statistic untuk patient, so kita assess balik and make sure all the blood immunization, whatever immunization that is being done has been reviewed. It's also safe for us to discharge the patient sebab medical legally, if patients come back, kita nak monitor macam tu lah. Okay, so kita boleh backup kita sebab kita dah roll out all the life-threatening differential diagnosis, and kita dah bagi tahu dia bila datang. Kalau tiba-tiba delay dah datang, kenapa, sebab apa, itu kita dah bagi tahu. So it's safe for us sebab kita dah bagi tahu.
Documentation others tu kena letak yang dekat kita punya notes. Dekat documentation notes tu others, masa dekat others tu we put the information for this and that. Masa buat notes dekat kan kita ada plan dekat others tu lah, others ada investigation apa semua bawah sekali tu lah we put the advice patient to
Make sure masa dah discharge. But not all yang datang abdominal pain semua pun you kena sebab mostly ada je yang mention yang memang yang you ada diagnosis is okay. Ni when you want to discharge is a non-specific abdominal pain. This is a very good one. And you have to be aware of the red flags, especially in the elderly or special patient. Be the treatment patient.
Actually, maybe the ones yang baru tak tahu, but previous actually
Hello. Okay. Actually, maybe the new ones yang tak jumpa green zone lama tak tahu that we actually have abdominal pain advice paper kertas. Yeah, all of this is on that paper. So make sure when you get patients with abdominal pain that you want to discharge, you have to give this. So when you document in your clerking that this has been given to patient and explain, then it should be okay.
No lah, betul. Because sometimes we are just focusing on surgical causes of abdominal pain saja. And then especially ada jumpa few cases lah, patient memang come with abdominal pain tapi ended up DKA. Memang it's not that uncommon. Memang ada cases dekat green zone memang macam tu. Just very vague abdominal pain, tak tahu dekat mana, semua sakit macam tu. But ended up is DKA. So I think it's good for us to like jangan neglect the medical causes of abdominal pain because most of us were like focusing on is it appendicitis, is it some AAA, adalah. So that's all. Thank you.
Okay, thank you, Ipis, thank you my friend. Jemput makan.